Thank you, Mr. Chairman, for your nice introduction, and thank you for invitation and possibility to talk. I will talk about tissue microenvironment, and we had already excellent talks about this topic. Just another one, my background and disclosures. I'm subspecialized nephropathologist and no competing financial interests. So a little of déjà vu. You've seen this slide already today, and I will not repeat. Other speakers had quite excellent overview. Just want to iterate that there are quite many players in this tissue or specifically tumor microenvironment, and want to highlight why it is so important, why we are heading into this direction. The main motivation is new immunotherapy, therapies which are arriving, and they're promising quite different added value for the cancer patients. If you compare the chemotherapy survival curve and then target therapy, they're not so different. So there's some added value in terms of patient survival, but if you compare the upper curves which show different immunotherapies, they are not just prolong the patient survival with free disease survival, but they also promise for some patients complete survival. So that's why there is a concept of cancer immunogram, and it was also mentioned today about the PD-L1 as one of the biomarkers which is quite problematic to handle, and immune cell infiltrates, TILs, other quite promising and maybe not worse or at least as good biomarker of not only prognostic but predictive information. So just to mention a few methods available. One of the pioneering methods is Immunoscore, and you probably know it very well. It's a quite strong prognostic indicator is in colorectal cancer, but also it's spreading out in other cancers. Another recent publication on it's called tissue phenomics to extract image-based biomarkers was performed on prostate cancer to predict 70 patients of prostate cancer to predict recurrence of the disease, and they used automated delineation of tumor glands and stroma, then applied some zoning around this delineation and actually searched for most predictive cell population, cell types, and their densities and their distances. And they found some combined biomarkers which could set a proof of principle that it's possible to extract reliable information from this area. So it's not only cancer, but also we have similar problem in allograft pathology. We also try to measure immune response, and what is common, we need to learn to understand the microenvironment and learn to measure the indicators that could quantify the information. And I'm going to present first results of our project which started last year. We call it Deep Context Tissue Analytics for Integrated Pathology Modeling in Cancer and Kidney Allografts. And this is the roadmap as we envision what needs to be done. So we start with the tissue. We have many methods of staining available, and then we have imaging techniques. But if you combine proper staining with proper imaging regimes, you may get new signals, new signatures for different tissue components. And then what you want to arrive is indicators of pathobiology, so proliferation, angiogenesis, fibrosis, etc. The final goal is to arrive to models of cancer and kidney allograft pathology. So in my second part of my talk, I will introduce briefly to these new imaging techniques that we are implementing in our center. And, we have some first results on that, and I would like to start with the disease modeling, what we're doing in this direction. So if you think about kidney allograft, this is kidney tubules, stroma, and you have peritubular capillaries around. So what we do in kidney pathology, we need to semi-quantitatively estimate the number of lymphocytes in the tubules, in the stroma, and in the peritubular capillaries. Of course, imagine it's semi-quantitative and it's easy in severe cases, but in borderline cases, you really have suffering deciding on which bound score you should achieve. So basically, you have the same signal as lymphocyte, but the location makes different biology and therapy. It's either cellular rejection or antibody-mediated rejection. If we look at the cancer tissue, you have this battlefield. You have core tumor, you have invasive margin that pathologists can see in many cases, and in image analysis tools, you can manually hand graph the margin where you think it is. Then it may provide a zone around this outline, but this is not so straightforward. And of course, it's easy in these nicely outlined cases, but if you have irregular tumor growth, it's not so easy, so it becomes biased. And how do you know what size of zone around this line you have to investigate? And if you look closer, actually the interaction happens not only in this so-called invasive margin, but it's also happening within the tumor. And of course, you can try to delineate each cancer gland manually or by image analysis tool, but again, remember this is a 3D structure and we are just looking at a 2D snapshot. So we questioned, instead of chasing the margin, can we just apply systematic sampling of this tissue and come up with some rules to compute the probability of specific area being an interface between tumor and stroma. And if you go to the internet, you can find these games which have similar concept. You have troops from both sides, and you have interface where actually the drama happens. And if you try to extract this area and measure what is happening in the area of interaction, you may get the most informative indicators of who is winning. So actually we did that. This was our study workflow. Standard immunohistochemistry for CD8, stained with Ventana Roche, scanned with Leica Perio. Then we used Halo AI classifier to segment the tumor and stroma tissue, then cell quantification, and then we processed the data into a new method which we called automated detection of tumor edge and interface zone. There are quite several steps. I just want to say the main things is first you actually compute the probability of interfaceness of each specific tumor area, and then around this area you detect the hexagons which are nearest to this tumor edge. Then actually you can rank these hexagons based on their distance to this tumor edge. So at the end you achieve this ribbon, which is not necessarily of equal width in all area, but actually it's a probability-based and rule-based detection of the area that we're interested in. And then we tested this approach on 2 patient cohorts. I think, yeah, okay. And these are just breast cancer cases and colorectal cancer cases, 100 patients in each cohort. So if you lump the data, this is just aggregated data, and you look at the density profiles within this zone from the left stroma in the left going into this tumor red, you can see that the profiles are quite similar. And you can also notice that there is quite abrupt drop of the lymphocyte density from the zone coming into the tumor tissue. But of course, we're interested in individual patients, and then you can plot individual profiles from these zones. And next question is how you express quantitatively what is happening. So we tested several indicators, and one that we named immunodrop was just a ratio between these two closest zones around the tumor edge. And the other was center of mass, which accumulates the change of the density towards the tumor. So we call this set of indicators immunogradient indicators because they show the directional density in the interface zone. So the first two samples are from colorectal cancer, and then at the bottom you see breast cancer. Of course, you can integrate information from various indicators because they all may keep some aspects of the thing that you're measuring, and this way we extracted two orthogonally independent factors. Of one is representing density level or abundance of the density, and the other was the direction of the gradient factor. And then we also just summed up factor scores of these two factors, thinking about that they both may have prognostic value. So we arrived to aggregated interface zone CD8 immunogradient. And I would like to show briefly the multiple Cox regression. We, of course, are curious if it provides independent prognostic value. Yes, and these are just prognostic models for breast and colorectal cancer, and either use primary variables or use aggregated factor. It provides good independent risk assessment of patient survival. And if you look at the Kaplan-Meier curves, just in parallel, they're quite similar in breast cancer and colorectal cancer. And I want to point one interesting thing that we found was some time-dependent distribution, time-dependent effect of this aggregated immunogradient in breast cancer. So what does it show? We have 10 years follow-up period. So first 5 years of follow-up, both patient groups do quite well. And it's early hormone receptor positive cancer, so it's a quite well managed disease. But after 5 years, you see the inflection point, and then the survival curves diverge, ending at 87 versus 55% probability of survival after 10 years. Why it's interesting, so one may speculate that the immune response property which we detect this way is encoded already in the surgical excision sample at the beginning of the disease. And then only after 5 years, maybe there are some dormant cancer cells which survive regular conventional cancer therapies, then do the job. And also one may question, could these patients benefit from immunotherapy at some point if you detect this population of patients? Just a sample of 2 breast cancer patients, low and high immunogradient, and you see the differences in their prognosis, although they are quite similar in other aspects. And in colorectal cancer, this aggregated immunogradient gave very nice dichotomization into equal patient cohorts, 50-50. So to summarize, we think that this tumor-stroma interface immunogradient is an automated, data-driven, explicit rule-based prognostic and hopefully predictive assay which has to be tested, obtained from a single conventional CD8 immunohistochemistry slide. Coming to the second part of my presentation, I want to show briefly new imaging techniques that we just have implemented, but why do we need? We have quite many techniques, and also multiplexing is providing huge opportunities, but multiplexing is quite expensive and it's tricky, and to implement it to clinical routine, it may be quite complicated. So another benefit from AI-based classifiers, and a year ago we implemented the Halo AI classifier, we found very good performance, and medical students just during 2 months created this segmentation of kidney compartments. It looked nice, but basically if you want to achieve some high precision, clinical grade precision for your applications, bright field, of course, has its own limitations. And for example, if you in the kidney, it would be very good to have peritubular capillaries outlined without immunohistochemistry. But still, best you can achieve in our situation is serious threat, but still there may be gaps, and this is just one of the little experiments to show why we need maybe to explore alternative new imaging techniques, and these are two of our collaborators in the project. Richard Levinson, probably you know him well. He's inventor of mousse technology used for unstained, unsectioned tissue. Now we are investigating the performance on paraffin sections. And Michael Schriebach from Marine Biological Laboratory in Cape Cod is inventor of another method, and I'll just show in the moment. So microscopy with ultraviolet sectioning excitation for paraffin sections. We call it thin mousse for a moment. It's a rather simple technique. You have UV lamp, LED lamp attached to your microscope at some certain angle. So it provides some excitation of paraffin section, and this was just one of the first images we produced from fat tissue. It's using stained tissue with 20x objective, and you get quite distinct signals for connective tissue, for red blood cells you see popping out of the capillaries, and there is some impression of 3D effect, or as they say, it's 2.5D effect. I don't know if it gives a benefit for image analysis, but looks pretty attractive. Another snapshot of kidney stained with just eosin. Again, you see red blood cells in the capillaries. What is interesting that proximal and distal tubules seem to provide different signal, and of course the glomeruli look quite distinct just with single stain. Another technique is polychromatic polarized microscopy, and now you're looking at a regular smooth muscle actin immunohistochemistry light in the glomerulus, and be prepared now to see the ppm. On the same field of view can generate alternative signal, which gives you polarized image of collagen in the same area, so it does not interfere with your bright field, which is very good. And what is the main benefit of this method over the cross-polarized simple polarization is that it gets signal from all collagen without turning the object. So it takes a snapshot and gives you complete representation of the signal, not just looking nice, but you don't need to rotate the sample. And in the tubules, again, the same immunostain, you can check the alternative signal, and maybe then you are lucky to segment out those tiny features per tubular capillaries for further analysis to have this context for your signals. And I believe there's more to come. It's a very beautiful unseen world that we're getting into, and I would like to acknowledge our collaborators in this project and our PhD students in the middle. Thank you.
Thank you very much. Any questions? I'll just try and sort of relate to a question that was asked earlier today in terms of looking at the microenvironment and looking at things other than the lymphocytes. I mean, you looked at the collagen as well. Were there any plans to sort of quantify the amount of collagen or the density of it, and was there correlation with prognosis?
Oh yes, collagen is another very powerful piece of information, and actually we have a poster. Mindaugas, who is here on this picture, is presenting a poster tomorrow. And what he found that even from small 1 millimeter diameter TMA cores from breast cancer, you can extract independent predictors of survival. So collagen, in my view, is important in two aspects. One is it's a good framework for your image analysis if you want to segment your context. And the other one is biological, meaning the tumor-associated signatures around the tumor may be also very relevant. So eventually, like I think one of the speakers this morning had presented this vision, you want to combine all these features into one major comprehensive model, both collagen, macrophages, immune cells, and of course not forgetting the tumor cell heterogeneity.